Well, good morning, guys. Grand Rounds for Mentoring Functional Medicine. Today we have case 5, and this one we kind of mentioned at the end last week. It's 29-year-old male with reflux. I would say you're probably going to see those about equal, male and female with reflux. That tends to be a pretty common one. I think we mentioned last time that like 40% of the population has reflux. There's actually some people that have silent reflux, so they just have coughing and stuff. I will tell you, we can dare to the biggest issues here, but sometimes medications are a big problem. Now we teach how to reverse this in the Mentoring Functional Medicine Diplomate program, and then have a little diagram and kind of explain all that stuff out, because it's a very simple thing. So for everybody that comes in, it is a complicated issue. Every other doctor that tries to fix this, or not ever fix it, but manage it, it is a complicated issue for them. But for us, it's a very simple process. So reflux is not a disease, or let's say not a abnormal outcome. It's a predictable outcome from an abnormal diet and lifestyle. So the mechanics of this, just so you know, kind of a background, is you have your esophagus, so you eat food, it's in chunks, it goes down into your stomach, and then at the bottom of your stomach is a sphincter called the pyloric sphincter, and then you have the lower esophageal or the cardiac sphincter at the top. These are just fists, circular, annular muscles that grip the top and bottom of this bag full of acid and enzymes. And so all that solid foods ends up in there, so we can break it all down into the smallest possible forms. So when it does release, after about 2 to 4 hours of churning, the top one gets super tight, the bottom one gets loose, the stomach wrings out all this, and it goes one direction into the small intestines or duodenum. We want it as broken down as possible with all those acids and digestive enzymes. Because that first part of the duodenum, the first 18 inches, is where you get about 80% of your absorption of nutrition. So if things aren't broken down in the stomach, they're not broken down and absorbing in the small intestines. And then the next 20 feet of ileum and jejunum is to slowly absorb nutrition. And then at that point, we're dealing with a milkshake, and then it goes into the small intestine, and 2 feet, sigmoid. All it does is dry it out. So it takes a milkshake, makes it in Lincoln logs, and then that absorbs 99.9% of the excess water. So your main digestion, main absorption of nutrients is really that first segment. Now, just because you put food in here doesn't mean that it ever goes into the rest of your body to build nerves and tissue and heart and hormones. Because your mouth is just a tube to your anus. You squish that together, you got a donut. It's just a hole. So just because it goes in this hole doesn't mean that it ever goes into your tissue. So our big consideration with treatment of reflux is making sure we don't shut down the absorption process or interfere with it, which is what they do. Now, if acid, when it's squeezing everything down, if acid squirts up and burns the esophagus, it is not because there's acid in your stomach. So you're supposed to have acid in your stomach. Every single human since the dawn of man has acid in his stomach. Every animal has acid in their stomach. But like almost all disease, it's a sudden, epidemic because we're causing this. So anything that's chronic is, what are we causing it? Or what are we doing to cause it? What do we eat, drink, breathe, rub on our skin, how we stress? All things we can control with this. So the main things when you look at diet and lifestyle, the very basic things for reflux to shut this off is what interferes with the sympathetic nerve. So you have 2 nerves that go to this. One is from your brainstem, and it says, do your job, no reflux. The other nerve comes from along the back of your rib cage. They look like a little string of pearls, and that's your sympathetic nerve, fight or flight nerve. And that one goes to all your organs and says, do the opposite. Crap your pants, have reflux, have super fast heartbeat, breathe really hard, and feel like you're gonna pass out. So sympathetic problem here. So sympathetic is overriding the parasympathetic and allowing that muscle to be weaker and acid to squirt up. The question becomes, what are you chronically doing to make sympathetic nerve? So it's always fight or flight, so lots of stress, you're gonna have reflux, right? But also wheat, dairy, MSG, nitrates in processed meat, sulfites in American wine and processed food, MSG in Chinese food and processed food and flavor enhanced food, chocolate, but that's just sugar milk for most people. Food sensitivities, that histamine drive actually will spike that sympathetic nerve. Is that it? Stress? Yeah. So you look at that, well, crap, that's what everybody's eating. So it's not why does 40% of the American population have reflux. It's more like why doesn't 100% of everybody have reflux? So I'm not surprised the ones that do, I'm surprised the ones that don't. Because they just eating crap and they not causing it, that's pretty impressive. So if we can make these dietary changes and stop triggering sympathetic nerve, then it stops weakening that muscle, and all of a sudden you get to live a reflux-free lifestyle. So we see reflux a lot. And again, this is case 5. We've been hitting just one thing, but again, we talk about we do that comprehensive intake. It's usually 30 to 60 other chronic issues that people have. So this is a very common thing, and it's always treated in the worst possible way. So this client, case number 5, 29-year-old male with reflux, approximately 5 years, and that's pretty common, and sometimes they call it GERD and reflux, heartburn, it's all the same thing. So GERD just gave it a disease name, right? Reflux is just the expression of what's going on there. So gastroesophageal reflux disease. And basically postprandial, usually it's always after you eat, but not always. It can be at bedtime, that kind of stuff. Heartburn, regurgitation, hiccuping, intermittent throat irritation, even to the point of you kind of lump this in maybe with eosinophilic esophagitis, where people, their throats instead of swelling out are swelling in, and then very quickly they snore a lot and they get sleep apnea, and then they also end up getting food stuck all the time. But it's all part of the same process, the same fix. So of course, quality of life, sleep sucks, trying to figure out how to get your bed angled up, because they say it's a lay on your back problem, which it's not. It's still supposed to be iron fist tight, even when you lay down. Eating that late at night, they often say it. What else? Quality of life, like definitely more experiences with restaurant meals and fast food. So concerns about eating out becomes a big issue because there's so much pain. And then also one of the big concerns too is that if you're having this pain, we also live in a country where everybody's having heart attacks and strokes. Is this heartburn or is this a heart attack? So that then is pervasive in the back of their head too, and dramatically changes quality of life for them. The typical medications that they come in, it's almost always the same one. It's omeprazole, any of the AZOLEs, azoles, and those are called proton pump inhibitors. And proton pump inhibitors work by blocking the pumps that produce acid or hydrogen, but those pumps also make intrinsic factor. And the intrinsic factor is what helps us absorb B12. So B12, when you make it through your gut bacteria and you eat it through your diet and take it as supplements, it has to bind intrinsic factor. And then it can be absorbed, and then it runs your brain, memory, mood, alertness, detoxification pathway through the liver, converting your neurotransmitters or amino acids into neurotransmitters like serotonin, melatonin, PEA, dopamine, octopamine, all that kind of stuff, even epinephrine and norepinephrine for kind of alert and drive or being effective. So all quality of life will shut down when you shut down the acid pumps, because it stops intrinsic factor from pumping, so you don't absorb B12. And then you can even make megablastic red blood cells, which then lead to megablastic anemia, and then you're just tired and fatigued all the time. And quality of life really sucks with long-term proton pump inhibitors. They can take Tums, naturally we occasionally, like if you're gonna have breakthrough reflux while you're getting off your medication and making lifestyle changes, well, a little baking soda and water is fine. Like that's not gonna harm you at all. But Tums are just a crappier version of baking soda and water. So that's at least a lot better than shutting down your intrinsic factor and your acid pumps, that's for sure. So typical medical treatment, they can't do very well. I can't do that very long. So it's usually should be focused on lifestyle, but they don't do lifestyle. They're not taught lifestyle. So they're not going to make any real dietary changes. A lot of times they tell you not to eat acidic foods, but that's the dumbest thing I've ever heard in my life, because your stomach is more acidic than what you could ever eat. If you ate stomach acid, it would eat your face and your esophagus all the way down to your stomach. You could literally eat a cow's stomach called tripe and it will digest in your stomach. So there's nothing more acidic than what's in your stomach. So even if you ate something like tomato or drank some coffee, which is kind of acidic, it is not more acidic than your stomach, which means it's alkalizing to your stomach. So all of that's just bullshit. You're not making it more acidic. Now, the stuff that they typically do for that kind of like acid prevention diet is, don't drink a bunch of sodas and eat a bunch of meat. You're like, okay, well, if they eat more fruits and vegetables and that's seeds, berries, legumes, and greens, they're probably going to be fine, right? But it's usually dairy and wheat are the two biggest ones to trigger that reaction. But sugar and MSG and sulfites and stuff that we talked about, those are all big ones too. So again, it's not a disease. It is finding your breaking point of how many toxic chemicals to stimulate sympathetic nerve response to that lower esophageal sphincter does it take before yours stops working. The minute you stop causing that, it goes back and it works again. That's why I love reflux and GERD, because it's just night and day difference. Once you get this figured out and you can explain it and understand it, they're not broken. The minute they stop causing it, it instantly just stops. It's not even like Crohn's and eczema where you gotta wait a couple weeks to have that old tissue healed and new tissue. It just stops. So patients are always surprised because they've been dealing with this for years to decades, and then they're just like, it just went away. And you're like, yeah, you should refer all those people to me. Now, that typical management basically is just shut off all the acid. And it works because if you don't have acid, then you can't have acid reflux. So that's a little success for them, but how long can you shut off acid and digestive enzymes and get rid of B12 before quality of life starts becoming a problem? And they do have anti-reflux surgery. Sometimes people can have a hiatal hernia, where it's just as the esophagus goes through the diaphragm, the hole's too big, so the fundus or top part of the stomach can kind of push through a little bit, and then it squeezes down, and then it traps that, and then when it relaxes, the acid comes up. But that's going to be your rarest possible. And we've had lots of hiatal hernias that are minor that just aren't symptomatic at all anymore. So just because they have that, sometimes they just tell you they have that without actually diagnosing it with imaging. So if it's really bad, you just pull the stomach down, put a couple stitches there, and you're done. But for most everybody else, it's just going to be dietary and lifestyle changes, right? Now, the way we go about this is really explaining the medication side effects for this, giving them like a baking soda and water or Tums kind of alternative through the transition period. And so we do the full intake, so we want to know the whole clinical picture of what's going on in their life. So what are the 30 to 60 other things you have going on that we can fix? And then we make dietary changes. We look at the food sensitivity test. Now, this is another place where, like the Crohn's, like food sensitivity testing is an absolute must, because those high histamines, you have 9 different ones, and the right ones actually cause that stimulation of the sympathetic nerve to cause that. That's why it also helps with everything else, right? So diarrhea and urinary leakage and dribbling and tachycardia and what else? A couple other things there, even gastroparesis. So we do that testing, identify which foods are triggering histamine reactions, get rid of those foods, and then as we make the other basic food changes, usually we see it gone by then. Like, it's a very quick thing. But the chemicals play a part in this. So again, we want to go through several visits where we detoxify their life. And then we want to go through several visits where we bounce their hormones back without taking hormones, because that neuroplasticity, resilience, stoicism, stress by itself, chronic stress, will actually stimulate epinephrine, norepinephrine, which is your sympathetic nerve response, and cause some reflux. So you have to calm down. So we always harp on that, like it's the same thing every time, you know. But it's just create a lifestyle that's consistent with life longevity without gimmicks and nonsense, and just make sure everything works and stays working for them. And then they go eat at Chick-fil-A, or they eat some, what was it, that one was McCormick's taco seasoning when they switched over to yeast extract, which is MSG. Oh yeah, they had symptoms. So other than that, should just be gone. No more lifting their bed up. So 2 months, which honestly is before that, but by 2 months, the outcome is marked reduction, elimination, and postprandial and nighttime reflux. So almost all of it completely gone. Usually by 2 months, we haven't got to the hormonal stuff yet, but that usually finishes everything out. But normal sleep, finally, not jacking their bed up, substantial reduced reliance on any kind of like baking soda or any of that for some breakthrough. So treatment of reflux and really fixing reflux or preventing reflux is a mechanical dietary behavioral contribution. So again, lifestyle. So yeah, you'll probably see a lot of people, all the stuff we talk about, a lot of people with reflux. But it's usually par for the course, because again, we do, chronic, all these things that they have going on, list of like everything falling apart. Reflux is usually in there somewhere. And then they just don't have reflux. So, all right. Kind of a simple one. And I hope, like, part of this, like when I do lectures and stuff for seminars, is kind of harping on the fact that this is not rocket science. It really is not that complicated. I probably could have learned this going through that diplomate course without spending hundreds of thousands of dollars learning what I learned, right? But what mostly I learned was what are the gimmicks and what are the nonsense things over all this time versus how does the body actually work? What do we do to mess it up? Just teach people stop messing it up. And it's always lifestyle stuff, always lifestyle. So we're doing the same thing over and over and over and over. And we're getting these profound grand round results. But it's just your daily boring, you know? Like, all these doctors are like, well, I've knocked their reflux down 30% over the last 6 months. And you're like, why do they still have it? So, hope you guys enjoy the grand rounds. This is my life's work kind of poured out. And so hopefully the easy, digestible kind of ways to give you hope. And especially to kind of redirect how you're treating your health coaching or clients or patients, okay? All right, next week, what are we doing? Case 6, oh yeah, okay, so 37-year-old female with migraines. I don't know, you guys might see more migraines than I do, but it's probably like 10% have migraines. But we have some with some really interesting auras and stuff, and repeating light patterns and all that, scintillating scotomas. So I feel like anytime we really get migraines, if we get them, they're always the severe ones, and they're the ones that medications aren't even touching anymore. And so that'll be a good case study. I don't think that's our scintillating scotoma one, but I see him next week, but it's been years. I don't think he has that anymore. So, like, I think he's been scintillating scotoma free for, 5, 6, 7 years now. So, all right. So I'll see you guys next week, and we'll wrap up Case 6